Our next speaker is Ahmed Alani, and he will present on adult idiopathic scoliosis. Is it different than adolescents?
So for idiopathic scoliosis, we pretty much know many of the issues, especially the outcome of surgery is more predictable and also complications are less frequent compared to the adult patients. But there are some gray zones still remaining, like what should we do for the curves between 45 to 50 degrees in the thoracic spine, especially in the late adolescent term. And sometimes we may face with, again, 40 to 50 degrees of balance curves that in the late adolescent time that may be difficult to decide on whether to operate or to wait. And the same thing is valid also for the lumbar curves between 35 to 40 degrees. So it is, as I mentioned, sometimes difficult to decide on at what time surgery is necessary for those late adolescents or early adulthood patients. And to understand the differences between the adolescent versus adult idiopathic scoliosis, we thought that may help us to decide on whether to do a surgery in the early period or wait for those patients until they have a certain amount of progression. And one of the other issues, especially that we face in our countries, we cannot follow those patients regularly every 2 or 3 years. So those patients with some adolescent idiopathic scoliosis may come to our office 20 years after, as with an X-ray that Ferran has shown in the morning session, with a huge deformity. And we know that, actually, we assume that there are some differences in terms of curve characteristics, like its severity and rigidity, when adolescent patients are compared to the adult patients. And also, there are some questions whether we can get the same amount of correction when we do the same surgery in the adult time period compared to the adolescent time period. We are also not very certain about the clinical outcomes. So just to answer some of those questions, we have done a study in our European Spine Study Group, and also seeing that there are not too many information about this sort of issues, like comparing the adolescents versus adults in terms of curve characteristics and also in terms of correction rates and the clinical outcome. And this is a study done by the study group, and here is the list of the authors. And we have presented this paper in the SRS meeting, annual meeting last year. And the aim was to compare patients with adolescent versus adult idiopathic scoliosis patients, again in terms of all the questions that were in our mind, such as curve characteristics, radiographic outcome, clinical satisfaction, and complications. This was a case control study, and we have matched 2 groups of one single surgeon, and we have, as he was the most senior surgeon among us and having the more number of patients, we have selected among Dr. Hamzoğlu's patients, and also to eliminate the surgeon factor in a multi-center study, we have chosen one single surgeon's cases. So we have grouped the patients in 2 groups, Group A, including adult idiopathic scoliosis patients, and Group B, the adolescent idiopathic scoliosis patients. All patients had the same technique, same idea of selection of fusion levels. Of course, it is slightly different in adult patients. And all patients had a more than 2-year follow-up. We have looked at the pre-post-op and follow-up X-rays in terms of flexibility and correction rates on the AP, lateral, and bending X-rays. And also we have done some surveys in order to understand the subjective satisfaction of outcome. We have also analyzed the complication rates. So as you can see here, the 2 groups were similar according to the sagittal plane parameters, and in terms of the main thoracic curve and also thoracolumbar and lumbar curve. The only difference was in the age. So the average age in the adult population was 25, almost 26 years old, and in Group B, the adolescent patients, it was around 15 years. And then we have looked at the flexibilities in those patients. And as you can see here, the younger patients had more flexibility compared to the older patients in the proximal, the main thoracic curve, in the proximal thoracic curve, and also in the main thoracic curve. But in terms of thoracolumbar and lumbar curves, the two groups were similar. So the flexibility rates were almost similar, but close to a statistical significance. And then we have looked at the correction rates after the surgery. And in terms of correction rates, as you can see in the chart, there was no difference in the proximal thoracic curve, but the correction rates in the adolescent groups were statistically significant, both in the main thoracic curve and also the thoracolumbar and lumbar curves in the adolescent population. So then we have looked at the number of fusion levels, and in terms of fusion levels, the number of fusion levels were similar in both groups with no statistical significance. And in terms of operation time, as you can see, the younger patients had less operative time, not significant but close to a significance. And when we look at the number of additional operations, the number of operations were significantly higher. I don't know, somehow it's missed here, that data. Significantly higher in the adult group compared to the adolescent groups. And although the number of fusion levels were similar in both groups, 5 patients in the adult group had extension of fusion to lumbar 5 vertebra or below, compared to no patients in group B. So in the group B adolescent patients, the lower instrumented level was L4. Then, as we didn't have the preoperative SRS-22 scores, we just analyzed the clinical satisfaction by using the global rating of change of scores for improvement and deterioration. And this was measured with a 15-point scale ranging from -7, no improvement, to +7, improved a lot. And comparing the two groups, again, the adolescent group had a higher score, which showed that they had better satisfaction with the surgery compared to the adult groups. And looking at the complications again, we have seen that adult patients had significantly higher total complication rate compared to the group B, which showed that these surgeries resulted with a higher complication rate in the adult group. These are two samples of the patients that we have studied. A patient, 15 years old, with a 61 to 28 degrees of curve, in quite flexible curve. And then we were able to get a good correction by stopping at L3 in this patient. But on the other hand, a similar curve in an adult patient who had 30 years old in age, who was 38 years old in age, due to degeneration in the lumbar spine, which was approved to be symptomatic by doing a discography, we have to extend the fusion up to the sacrum. So, as a conclusion of this study, we considered that idiopathic scoliosis in young adults had different intrinsic curve characteristics with more rigidity and with less correction rates compared to the adolescent patients. Posterior instrumentation, on the other hand, provided lesser correction, longer fusions, and more complications. And interestingly, although we are not sure about the minimally important clinical difference, the adolescent patients had better improvement in their satisfaction compared to the adult groups. This study, of course, has many flowbacks. First of all, it's a retrospective study. But I think this is a result that maybe we should discuss with our patients who are in the gray zone coming to us in their late adolescence or in their early adulthood ages. And we should know them, we should notice them that the later surgeries in the later ages may be more, may provide maybe less satisfactory correction and less satisfactory outcome. And we should warn them, especially perhaps to come close to the follow-ups and to be under control if they do not accept to have surgeries. Thank you very much.